A 65-year-old male patient, accompanied by his relative, presented to the emergency room at 2 p.m. today in a restless state. On history taking, relative told patient has a burning sensation in the chest, one episode of vomiting and increased sweating since 6 a.m. in the morning. Thinking that the patient has a simple kind of indigestion or acidity, they had given patient tablet pantoprazole 40 mg and tablet ondansetron 4 mg. But patient does not get any relief, and after few hours patient chest discomfort was increased, patient felt more restless and has increased sweating and more episodes of vomiting. So they bring the patient to the hospital. On further history taking, they told patient is a known case of diabetes since 2 years and is on tablet metformin 500 mg OD. Patient also had a history of alcohol intake 2 days back. On clinical examination, his BP was 90 by 70 millimeters of mercury, pulse rate was 60 per minute regular, SpO2 93% on the room air. On further clinical examination, his cardiovascular, respiratory, CNS and GI examination was normal. His ECG was taken and ECG seems to be this. So in ECG you can see there is ST elevation in lead 2, 3 and AVF with depression in lead V2. This is suggestive of acute coronary syndrome, that is inferior valve myocardial infarction. So what was missed in this patient? Look at the statement in the Harrison. Frequent location of pain beneath the xiphoid and epigastrium and patient denial that they may be suffering a heart attack are chiefly responsible for common mistaken impression of indigestion. It is often accompanied by sweating, nausea, vomiting, anxiety and sense of impending doom. And look, the proportion of painless STEMI is greater in patients with diabetes mellitus and increases with age. So whenever an elderly male or female come to your OPD or emergency room with a chief complaint of burning sensation in the chest or epigastrium or abdomen discomfort with GI symptom predominantly like nausea, vomiting, always rule out cardiac cause, always do a ECG, always do a cardiac biomarkers. In a patient of diabetes, there may not be a classical cardiac chest pain. So always rule out ischemic heart disease and acute coronary syndrome in an elderly patient coming in late in the night or early in the morning. Always do an ECG.